I think that this is an area that is exploding. Working with drug development, I see new agents all the time with unique targets I never heard about, with targets I have heard about used in a different way. So I really think we're going to see more and more bispecifics. A lot of these drugs are used second line, third line, fourth line. I would not be surprised if they move up in treatment, especially as we learn safer ways to give these drugs.
You're listening to the ONS podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Hello and welcome to the ONS podcast. I'm your host, Jaime Weimer, Manager of Oncology Nursing Practice at ONS. And today we're talking with Rowena Moe Schwartz, Professor of Pharmacy Practice at the James L. Winkle College of Pharmacy at the University of Cincinnati in Ohio, about bispecific antibodies. This episode is part of a series about anti-cancer drug classes, which we'll include a link to in the episode notes. This episode provides free NCPD contact hours. To receive credit, please review the episode notes for any guest disclosures before listening. Following the episode, complete the evaluation linked in the episode notes. Welcome back, and thanks so much for joining us again today, Mo.
Thank you, Jaime. It's wonderful to be back.
Let's start with an overview of the history of bispecific antibodies in the field of oncology.
This is such an interesting question because I decided to do a little digging to make sure I knew where things started back from. And it actually was in the 1960s that there was this concept that you could merge parts of antibody to get a bispecific, but it took all the advances in engineering, genetic engineering, recombinant DNA technology before they started to first do work on these types of agents. So the process has been around for a while. It was in 2014 that I think most of us think of as the beginning of bispecifics in cancer, and that was with the approval of blinatumomab that was granted accelerated approval for the treatment of patients with Philadelphia chromosome negative relapsed or refractory B-cell precursor, ALL. It is a bispecific that targets CD19 expressing tumor cells and CD3 on T cells. And so it's the original bispecific T-cell engager. Is often called a BiTE because that's the proprietary name given to it by Amgen. So it was the first. Now, since then, there was a little bit of a time where we didn't see new agents. And then all of a sudden, we've seen more and more be developed and marketed. So in 2021, we had amivantamab, which is a bispecific that's used in certain types of EGFR mutated lung cancer. Then in 2022, that's when we saw a number of agents for both lymphoma and myeloma. And then in 2024, we saw a new agent, as I say finally, because I'm so excited for small cell lung cancer. And we've seen more drugs be developed and marketed since then. So it's really taken off in the last maybe 5 years.
Absolutely, it really has. And I do remember the first release, blinatumomab, and just how many questions we had. How do we deal with this drug? And just to realize how quickly we've added so many other drugs to that same class and how familiar nurses and pharmacists we've all become with understanding how to use these drugs and how to care for our patients that are receiving them. So it has been sort of a relatively brief and very quick escalation to where we are today. So a very important episode today. And I know lots of nurses will be interested to hear more about what you have to share with us. So what are the different types of bispecifics? Now you mentioned, I heard you say it a little bit like a BiTE, a T-cell engager. So let's talk a little bit more about that. What are the different types of bispecific antibodies that we currently have on the market?
This is my absolute favorite topic to talk about because I think it is one of the areas that people get so confused about. The term bispecific means that this is a protein, an artificial protein that's developed to hit simultaneously two different antigens. And they can be two different epitopes on the same antigen. We'll talk about that in a second. They can be an antigen on a cancer cell and CD3 on a T cell that kind of recruits the T cell to the cancer. So there's different types. The subtype that we often talk about are bispecific T-cell engagers, which are those bispecifics that do target the T cell. And currently, the target on the T cell that is utilized is the CD3 molecule. That's not the only one that will be used in the future because there's a lot of work being done on other types of T cell engager. I also want to mention something that's kind of new recently, and that's a term that's, well, it's new to me, and it's called a biparatopic antibody. And that is a bispecific that hits two distinct, non overlapping epitopes on the same antigen. So there's a drug that was approved this year that I'm going to say it slow so I say it right, zanidatamab, that hits two extracellular domains on HER2. One is the same extracellular domain that trastuzumab hits, ECD4, and it also hits ECD2. So you can see there's really lots of unique ways to hit two targets. And the bispecific T cell engager is a subset of bispecific antibodies.
Thank you so much for reviewing that. And I do think as more agents come out, as we see these continue to come out, and as you've just noted, all of the targets start to become very nuanced, very different. It is important to always keep in mind that not all bispecifics are bites, but all bites are bispecifics. I remember hearing you say that at some point, and so I've remembered that ever since then. So keeping that distinction, and really it's just about knowing what are the specific targets of the drug that you're giving. And so let's talk about that. What are some of the options? I know you mentioned a couple already in those examples, but what are the most common options we're seeing in terms of targets for these bispecific antibodies that we currently see on the market?
The group of targets that I think we've seen a lot of activity in terms of drugs is the targets for lymphoma being CD20. Those are bispecific T cell engagers. Those are bispecifics that hit CD20 on the lymphoma cell, as well as CD3 on a T cell. So we have a number of agents that hit that have been out for a while and are in use. In myeloma, we have two different targets that have been utilized. One is BCMA, or B cell maturation antigen, that sits on the surface of myeloma cells and on some healthy B cells. Great target in myeloma. And we have, I think, 2 to 3 agents. A new agent just came out this year that hits the bispecific T cell engager for BCMA. There's also a target that's used in myeloma that's called, and this one I always have to read so I don't say it wrong, GPRC5D, which stands for G protein coupled receptor class C, group 5 member D. And this is a protein that is predominantly found on myeloma cells, but it's also found on some hair follicles. And so that becomes important when we talk about toxicity. So there's 2 different targets that are used in myeloma. In small cell lung cancer, there's a target that probably most of us didn't really know much about until it became a target for a bispecific T cell engager, and that's delta-like ligand 3. It's part of the Notch pathway. This is important because this is overexpressed in almost like, I think it's something like 85% of small cell lung cancer. Great target in small cell lung cancer, being looked at in neuroendocrine cancers beyond small cell lung cancer. And then this year, we've had a couple agents that have come out that target HER2. And so we have, as I mentioned, the drug that targets 2 epitopes of HER2, and we have a bispecific that targets HER2 and HER3. That's actually, it is limited to patients that have a specific mutation that turns on that HER2 pathway. And then, of course, the one that I mentioned is one of the first agents we've ever seen, amivantamab. It targets EGFR and MET. And it was actually developed because when we have patients that have EGFR mutations in lung cancer and we use EGFR inhibitors, they do so well. After a time, there's resistance. So the MET pathway is thought to be important in that resistance. So this was actually developed as a way to get around resistance developing, and it's been used broader than the initial application. So you can see lots of different targets. And one of the things I see in clinical practice in terms of drug development, a lot of the agents that we're looking at have targets that I've never been aware of. They're important in the biology of certain cancers, and therefore there are drugs being developed that are targeting those. So fascinating.
Absolutely. And it's a little comforting when you hear a target that you are familiar with, like when you hear HER2 or EGFR, you're like, okay, wait, I have context for that one. I can probably extrapolate maybe some information that I already know. But as you mentioned, we're hearing about targets that maybe have no other therapy we've ever given that specifically targets that. So really an exciting time, certainly a challenging time to keep up with all of the science that accompanies the drugs that we're being asked to provide to our patients, but an exciting time to be a nurse in oncology and to be able to share these new therapies with our patients. So aside from the targets themselves, are there any other differences between bispecific antibodies that target T cells or are considered T cell engagers and those that are not?
The thing to think about with bispecific proteins that are T cell engagers is one of their main purpose is to bring the cancer in alignment with the immune cell, with T cells, to initiate the immune response. And so the target on the T cells, as I mentioned, is CD3. This is important for T cell activation and for signaling T cell in that immune response. So when you're looking at bispecific T cell engagers, their purpose is to elicit the immune response at the cancer cell to cause cancer cell death. And so you're going to see some of the impact of that immune response. Cytokine release syndrome, ICANS, those type of things that you think about when you think about CAR T cell, because you're eliciting that immune response. Those are very common with bispecific T cell engagers. And those are not what we see when we're looking at bispecifics that do not engage the T cell. We may have infusion-related reaction because these are big proteins that are not made by our body, but you don't see that same immune response that you see with bispecific T cell engagers.
Thank you for that clarification, and certainly an important point. We'll touch on more about toxicities here shortly, but before that, one question I had was, in terms of determining eligibility, which patients can or should receive these types of drugs, are there any sort of biomarker tests that need to be performed that we as nurses should anticipate looking for that would determine or that would show a patient should be prescribed a specific bispecific antibody? Or how would this differ for the T cell engagers? Are there any sort of qualifying biomarker tests that we should anticipate?
This is a phenomenally complex answer because it is so dependent on the clinical situation that the bispecific is used in. So this is a great question. So for certain cancers where there is an expectation that the target is going to be there, you may not require testing to make sure that cancer has that target before you use the agent, just like we do with other types of targeted therapy. Some targeted therapy, we have to make sure that it has the target. Sometimes we know that the target is so common in that cancer that we don't even do testing. It's the similar type of situation that you're seeing with these bispecifics. And I watch as they're approved to look to see, is there biomarkers that have to be present for the drug to be used? So for certain agents, like for lymphoma, it does not carry necessarily the labeling that says CD20 positive. We know that because they're used second and third line, fourth line, that patients, we know if they're CD20 positive. Not all of the targets are something that we test for. Now, that's not true with all, though, because I mentioned the drug. It's called zenocutuzumab. It's a bispecific that targets HER2 and HER3. And when you think of that, if you're like me, HER2, HER3 must be breast. No, not in breast. It's actually approved for patients that have a specific mutation, NRG1, which is neuroregulin 1 gene fusion. Now, when there's a fusion of this, a mutation of gene fusion in this NRG1 that turns on the HER pathway. So this drug, which targets HER2 and HER3, is indicated for, is approved for patients with advanced unresectable metastatic small cell lung cancer that have this mutation, or in those patients that have unresectable, advanced unresectable or metastatic pancreatic adenocarcinoma harboring this mutation. So with that one, yes, there is a very specific biomarker that we need to look at. In other biospecifics, it does not require the biomarker to be present. Did that make sense, or did I go too much in a circle?
No, I mean, I think to me, the big picture is that, a bispecific is really just describing the structure, the engineering of like, what does it do? It attaches to two different things. It targets two different things, but what those two different things are can be very different. And so to me, it reinforces that each agent really has to be treated unique because it is unique. And, as more of these come out, we might see additional drugs in the exact same sort of grouping or with similar targets. And so we might see some of affinity of certain agents kind of being the same way and requiring the same type of testing. But at this stage of the game, yes, there are several of these agents out, but each one can be just so different from the other one that to me, it's just a reminder, look at the package insert, understand what drug I'm giving, what are the targets, what does that mean for the patient? And it is complex, right? So there really isn't a simple way to answer that question. So maybe I gave you an unfair question, but thank you for that. I mean, I think it's a very nuanced response that just shows how complex and how unique each of these drugs could be.
I think your point is so important that we have to keep looking at what the FDA labeling is. Because if I look at amivantamab, that has expanded its application. And so the places where it's used and the type of mutations that we target, the type of lung cancer with certain EGFR mutations have increased. So you're right. We have to look at what the indication is and what the evidence is. I think that's so important.
So let's talk a little bit more in depth now about toxicities. What are some of the common toxicities that we're seeing for these different types of bispecific antibodies?
I'm going to give you two answers that I think of in my head right away. One is that it's very dependent on what your target is. So we've learned that, from EGFR inhibitors from the beginning of how I think of targeted therapy. And if it's an EGFR inhibitor, we know that it's going to have dermatologic toxicity. So that kind of thing is really important. And what is the bispecific T cell engager that's used in myeloma that targets the GPC5D? I think I probably missed a letter there, that targets myeloma cells. That is also expressed on those tissues that produce hard keratin, like hair follicles, and actually within the tongue. So the toxicities that we see with that agent, something that you wouldn't expect to see if you were using a myeloma agent, you see nail and skin issues. You see taste problems. So it's very specific about the target, which says to me that every time a new one of these agents come out, I have to learn about the target that helps me learn about the toxicity. I kind of find that fascinating and really appreciate that. These toxicities are very broad. But then if you're talking about the bispecific T cell engagers, not only are you talking about the target on the cancer cell it hits, you also have to talk about the fact that you're hitting CD3 on T cells. And so you're eliciting that T cell response and you're seeing that those kind of toxicities that you get when you elicit the immune response. So you're seeing cytokine release syndrome. You're seeing immune effector cancer cell associated neurotoxicity or ICANS. And so it's very specific for bispecific T cell engagers to think about those type of toxicities.
So you just mentioned CRS, ICANS. Certainly those are, I think, buzzwords that we are increasingly familiar with as oncology nurses. Can you explain just in a little bit more detail how bispecific antibodies can incite that CRS, that cytokine release syndrome, or the immune effector cell associated neurotoxicity syndrome or ICANS? What is the sort of mechanism of action of that toxicity?
So bispecific T cell engagers that recruit CD3 positive T cells are designed to recruit an immune response at the cancer cell. And so this leads to inflammatory cytokines such as IL-6, tumor necrosis factor, interferon that causes that cytokine release syndrome that can manifest in capillary leak, but in many other types of effects such as fever. I think most practitioners that work with CAR T cells are really familiar with this. Those of us that don't live in the CAR T cell world really need to make sure that we know how to deal with CRS. And I think that most places have developed guidelines for monitoring because it's so important. ICANS is not as common and probably not as well understood. It involves endothelial activation and blood-brain barrier dysfunction, causing inflammation within the CSF. There's some pro-inflammatory cytokines that are thought to be responsible. So again, those strategies that have been developed for monitoring these two complications of CAR T cells can be adapted to work for bispecific T cell engagers.
Great points. And as you said, even if you are not a practitioner in the CAR T space, make some friends in that space because they have learned how to address these symptoms or these side effects. And so we don't have to reinvent the wheel. If they've learned what they need to know how to handle these, then we can borrow that when we're dealing with the potential and the risk for the same side effects that come from certain bispecific T-cell engagers. So a great tip there.
So I was looking through in our cancer center within our hospital, we have resources, and I was looking for something to look at sensitivities for an organism. And I came across this resource that had been developed that's used mainly in the transplant CAR T cell world about bispecific T cell engager complication management. And I printed it off. And I thought, it's funny how much I'm digging through the resources already developed to make sure that I keep up on this kind of information. So I think that that's really important to, like you said, work with the friends you have within your institution that do this every day.
For the toxicities that you've mentioned, are there any strategies, pharmacologic or otherwise, that can help to either mitigate or treat those toxicities?
Cytokine release syndrome has been one of the areas that drug development is really focused on to see how they can help mitigate the severity, not only the incident, but how severe it is for patients to help move them to outpatient as soon as possible. So the strategies that have been incorporated, have been studied in clinical trials, you'll see used now is this step-up dosing scheme where you give initial small doses and over time increase the dose to the dose that you're going to continue with. Usually monitoring in the hospital is required by the FDA approval for anywhere 24 to 48 hours for the first couple of doses. And that's a real common strategy that you'll see. Pre-medication with H2 blockers, H1 blockers, sometimes steroids. These are also things that are incorporated within the approvals of these drugs and are important to look at. Sometimes there are recommendations to extend the time of the infusion if patients have experienced CRS with a prior dose. That's very agent specific. One of the big things that we're looking at now is sub-Q versus IV administration, and that's happened with a couple of the drugs that are commercially available. The other thing that I think people forget a lot, and I remind myself constantly of, is the maintenance dose frequency. So if you have a patient who needs to stop dosing for a while and has to restart, there is step-up dosing that is often recommended with the restarting. So it's really important not to think of this is the fourth dose, this is what I do. You need to look at if they've been on the schedule routinely or if something's happened, which happens a lot. And then the other thing that has been looked at is something that is in the FDA approval for glofitamab, and that's where they give a single dose of obinutuzumab prior to starting the bispecific T-cell engager to help deplete circulating and lymphoid tissues B cells. So there are like pre-medications that can be given. Lots of different strategies that are being looked at to help mitigate. And then, of course, probably the most important thing is the monitoring parameter after they receive the drug, whether it be during the hospitalization, or whether they go home, and that there's good communication that patients call if they have any change in status.
That's all great information. I heard you mention a little bit more about like moving to the outpatient and once they get discharged. So let's talk a little bit about sort of just the logistical piece of the administration and what considerations nurses should know about and keep in mind when they are caring for patients who are receiving bispecific antibodies.
The thing with administration is it's very dependent on the agent, what the requirements are. And I would very much recommend people go to package insert because it is outlined well. And it talks not only about how the infusion time and the pre-medications, but also the changes over the course of therapy. So certain agents have a lot of infusion related reactions. And so they may be, the first dose may be a split dose on day 1 and 2 because of that incidence of infusion related reaction. It is essential to look at the specific agent to see what the requirements are, to see what the pre-medications are, to see if the pre-medications need to be changed. If a person experiences infusion-related reaction or if they experience for the bispecific T-cell engagers, CRS. So it's very specific to the agent.
So as we are counseling our patients and their caregivers and families, preparing them to start on these types of therapies, what are some of the primary education points that we should be sure to communicate when we're preparing them, for what to expect, not only during their infusion, but after their infusion when they go home?
The bispecific antibodies, each specific agent has its own set of understanding of things that need to be considered. I think of it like how we think of chemotherapy. All chemotherapy is not the same. And so we tell people different things with different agents. And I think that it becomes important that if you work in a specific area, you work with lung cancer, that you learn about the unique aspects of the agents you use within lung cancer. If a new agent is approved and you're starting to incorporate it into practice, it's important to really dig into that initial trial to see what they did to optimize their care. In terms of what we teach patients, again, it's very drug specific and not class specific, as we've talked about, that we make sure that they understand the toxicities associated with that specific agent. I think with groups of bispecific T cell engagers, there's a little bit more uniformity in terms of helping them understand risk of of cytokine release syndrome, of ICANS that we can help educate them for. But I think the take home point is agent specific education is really important.
And you sort of alluded to it, is we can't teach about a drug if we don't understand the drug ourselves. And so to be able to confidently and reassuringly provide that information to our patients, we have to make sure that we feel confident about what we're trying to teach them about. And so it is so important when these drugs, if it's the first time you've given this drug yourself, or it's the first time it's ever been given in your institution, just so important to make sure that there is awareness and time to prepare and time to feel comfortable and to discuss with your pharmacy, as nurses, with our pharmacy colleagues, with our physician colleagues, to understand, why is this drug being given? How is it different from what other drugs I know about? What are these important points for me to know and for me to be able to share with our patients? So really, with any drug you give, we should be starting and making sure that we feel comfortable about what we're doing. But if you've given Taxol a million times, then you feel pretty comfortable with taxanes. But these are drugs where you might not give them in the frequency that gives you that comfort. So it is okay to always start from the beginning, teach yourself first, and then be comfortable and confident to teach your patients as well. So Mo, how do you see pharmacists and oncology nurses working together and collaborating to help not only manage adverse events and toxicities, but to also provide patient education and really serve as that trusted source of information for our patients and their caregivers?
So one of the things I think is really important as these agents are approved and we're incorporating them into practice is that when we develop the order sets in our electronic health records, that we develop them collaboratively to give clues about things that we should be looking at each step in the process. Because there is, like for the bispecific T cell engagers, there are these step up dosing. It's really important to know what happened the prior dose. And as patients move from inpatient to their outpatient administration, for the nurses and the caregivers within the outpatient to know what happened inpatient. So I think that is a collaboration in building these order sets and a collaboration in how we document. So it's easy to go and find information and not have to dig through every time you're going to give this drug to a person. That's probably one of the most important things. I think education across the board becomes really important. For a while, these drugs were used mainly in hematology. So that's where a lot of the information existed. And then we had a drug used in small cell lung cancer, and that's our solid tumor focused team. So it's really important to make sure there's education for the healthcare team that cross over specialties. In terms of patient education, I think it needs to be developed before we treat our first patient to figure out what's the best resource that we're going to give patients.
So Mo, what do you think the future looks like for these agents, and how will their role continue to evolve in the landscape of cancer care?
I think that this is an area that is exploding. I can't believe how much it is exploding. Working with drug development, I see new agents all the time with unique targets I never heard about, with targets I have heard about used in a different way. So I really think we're going to see more and more bispecifics, some T cell engagers by different mechanisms than looking at CD3 on T cells. And so I think we have to really make sure we understand the drugs we're dealing with. The other thing I think is that we're going to see applications move. A lot of these drugs are used second line, third line, fourth line, I would not be surprised if they moved up in treatment, especially as we learn safer ways to give these drugs. I was looking at something the other day and I learned about this work being done to make bispecific T cell engagers that are antibody drug conjugates, that those are combined. It says to me that I don't even know what kind of advances that science is going to bring with the understanding of the cancer, but also with the ability to build these drugs to be more efficacious for cancer treatment.
Wow, that's amazing to think of that. These two new drug sort of concepts like merged together into one super complex drug. But again, it's what we've been after all along is a super targeted, super customized, personalized treatments. And that might make them very complex. But as oncology nurses and pharmacists, we are up for the challenge of learning about all of these new complex drugs and how to help educate our patients so that they're ready as well. So certainly very exciting. Mo, thank you so much for all of the great knowledge that you brought to our listeners today. I certainly always love talking with you and I learned so much. As we reach the end of our episode, I'm going to ask you a few quick questions just to help summarize some of the things that we've talked about today. And to start that off, how do you think healthcare professionals, how should we evaluate any hidden or implicit bias we might bring to our care for our patients about bispecific antibodies? What hidden biases might we have about bispecific antibodies that we need to check before we work with our patients?
The truth is, not all bispecifics are T cell engagers. We think about them that way because those were the agents that we first started to hear about. So yesterday I was in clinic and a provider I work with, he has an opportunity for a new study. And he said, "What do you think about this new study? It's a bispecific." I immediately went to bispecific T cell engager in my head, and it was not. And I say this constantly. My husband knows this and he doesn't work in oncology. He's retired. And I say this so much. My first thought was bispecific T cell engager. So I think that is one of the things that we are still working through because we're so used to when people talk about bispecifics, they're talking about blinatumomab or they're talking about the bispecific T cell engagers for lymphoma or myeloma.
Well, there's also that very handy acronym, BITE. BITE is easy to say. It's easier to say BITE than bispecific antibodies. But again, that's an important distinction that we keep, that not all bispecifics are BITEs. And as you mentioned, we can be very well versed in these treatments and still make some assumptions until we stop and ask ourselves to explore that a little bit more and make sure that we're having all the right information as we process these things in clinic. So thank you for that example. Are there any other common misconceptions that you think about for bispecific antibodies?
I think that historically, because they've been used in hematology, I think many people who are practicing and busy with their focus don't realize that the whole concept of bispecific antibodies is extending way beyond hematology to solid tumors. And I think that that's one of the misconceptions. And so these are agents that have really great potential. I personally think they're going to move up from fourth line, third line, second line. And so I think that that's some of the misconceptions that people have.
What's something about this topic that's not often discussed, but you wish people knew more about?
Well, we talked about it, but I still think it's a big problem. And I think that's that when a patient is on one of these bispecific T cell engagers and their therapy is interrupted, that you have to think about how you're restarting. And it depends on how long they've been off. It depends on what the drug is, but it really takes thinking about where they are in therapy. And, it's not just their third dose. Is it their third dose in 3 weeks or is it their third dose in 6 months? I think that's one of the big things that people don't talk a lot about. We talk about the step up dosing, but the need to re-step up maybe. Those are some of the things that we need to think about in practice when we're very busy and probably don't have as much time as we should to think about those things.
What additional training or education do you think oncology nurses need to stay current on this topic?
I think this topic needs to be integrated into what we have classically called chemo courses because these are such a big part of what's going to happen in therapy. There's lots of review articles out there. Yesterday, when I got home from work, I picked up my journal from HOPA, and there was a review article on bispecific T cell engagers for myeloma. There's lots of stuff out there for people. So I just encourage people to read those general articles in maybe the ones about the drug that you're using.
And are there any additional resources you would recommend for patients or even other providers who want to learn more?
I'm a big fan of we've talked about this a lot. I feel like this is one of my broken records, and that is I'm a big believer in the package insert. The package insert provides so much practical information. I love going to the primary study and reading it because there's often an explanation of why what was done was done. And I think that's really helpful information. But when I'm busy in clinic, it is that package insert that has that information. And I think that is certainly something to look at. In terms of general learning, I appreciate that ONS, HOPA, ASCO are putting out programs that talk about these agents from people that use the drugs every day. I think that really helps us feel more comfortable with what we're doing when we're treating patients.
Well, Mo, thank you again for sharing all of your knowledge and your time with us today on the podcast. It's been a pleasure talking with you and really an exciting topic to share with our listeners that I think, as you've mentioned, will only become more common for us to see in a variety of indications in a variety of settings. So thank you for refreshing all of our knowledge and our memory on what this therapy holds for the future. Do you have any final comments to share with our listeners?
No, I just really appreciate this opportunity to talk about this. So many new agents that are coming out have indications that are probably pretty small, biliary tract cancer, certain types of lung cancer with certain mutations. The drugs that come out may not be ones that we see, but they may be ones that we need to know about for that particular patient, that specific patients. So I really think this is a great opportunity to talk about those advances. So thank you very much.
Thank you so much, Mo. Thank you for listening to the ONS podcast. Tell us about your favorite part in this episode by leaving a review wherever you download your podcast. For more resources and information about oncology nursing, visit us at ons.org and ons.org/voice. The ideas and opinions shared in this episode represent those of the guest and not necessarily ONS.